One of the things that our government does is give subsidies for production of bad things, animal products, high fructose corn syrup, refined flour, sugar, those kinds of things to make them less expensive. And once you do that, then the poor people are more attractive to it because it's inexpensive calories. And then we have to pay collectively for the healthcare of the poor. So why would we do that?
Dr. Williams, it's such an honor and pleasure to have you. What you don't realize, the audience doesn't realize, is that he and I, Dr. Williams and I, have been chatting for the last 30 minutes about life and about our personal problems and personal issues, and it's been such a lovely journey. But what I really wanted to do in this podcast, just to give you a little background, Kim, is, I started this actually because I think there are too many people out there in the nutrition world that maybe are giving out information that's not maybe always clear, or maybe not as accurate as I would like it to be. And so I thought, as a physician, that if talking to physicians, I thought that would be an important topic to just kind of clear the air. And the second thing I thought is that there's just so little, there's a lot of lack of social connection right now, and a lot of sadness in the world. And so I just thought, if I could bring people a little bit of help in the nutrition world, and then also a little bit of joy in the way we talk about it, maybe I will have made some impact. So that's that. So when I was thinking about you, I was thinking about your beautiful talk you gave at PCRM recently about healthcare and implicit bias, and just really the bias that exists in healthcare, socioeconomic status in relation to healthcare. So I thought those are the topics we would cover today. Now that you are in Louisville, Kentucky, you are dealing with a lot of a different demographic of people. Maybe you can start there and tell us about the community you took care of in Chicago and Louisville. And as an African-American person, what can you tell us about the demographic and how the impact of a socioeconomic status impacts health?
Well, first of all, I have to say that thank you for having me and to talk about these difficult issues. And I know some people think that my views on this are a little strange, or maybe a little bit too idealistic, but I think that we have opportunities to try to help with these issues, but because of what we do in terms of prevention and nutrition. But having said that, I came from the South Side of Chicago. I grew up, I like to say I'm from Inglewood, Auburn Park, or Chatham. Well, the honest truth is, we were so poor that they would never renew our lease. So I ended up going to 8 different grammar schools and ended up, all over the South Side of Chicago. So suffice it to say, I know exactly what was going on there, and how the healthcare system worked, and that is what stimulated me to go into medicine. Why bring up the South Side of Chicago? Because yes, the West End versus the East Side of Louisville has about a 16-year life expectancy difference. And that's one of the largest in the nation, but it's nothing like Chicago. If you go from Inglewood on the south side to Streeterville, which is up by the Mag Mile, that people love to shop and all that, up by Northwestern, that's a 30.1 year life expectancy difference. And so pretty much all of my career, whether I was at University of Chicago on the south side, or Midtown Detroit when I was at Wayne State, to moving to the west side with Rush University, and now at Louisville, I've always been struggling with the fact that we have these healthcare disparities, and they're so multifaceted. They have to do with finances and education and historical values and historical health issues. That I had a patient just a few minutes ago, that's on the inpatient service at University of Louisville Hospital, tell me that no, his disease, his hypertensive heart disease and blood pressure that's impossible to control, he inherited it from his parents. Well, what I'm trying to say is, no, what you inherited was the lifestyle. That is, a lot of times when we're trying to change someone's lifestyle, it's a kind of an attack on their family and their upbringing and maybe their church and their community. And we have to get people to understand what's really healthy. And that's where all the social determinants of health come in, because if we don't have health literacy and education are inexorably tied. And so we really need to focus on education, try to get people to understand what the disease processes are and how we can prevent them. Because we have plenty of guidelines, but the guidelines without application, without implementation, mean nothing.
No, that's great. I love that. So can you talk a little bit about those social determinants of health and sort of what you see as some of the biggest areas of gap?
So the gaps and then the opportunities, and they really are the same. When we got very, very acutely aware during COVID of people dying when they were more so when they were people of color, it's because they couldn't just all of a sudden, when I got COVID, sure, what did I do? I stayed in bed for 4 days. 2 of those days I had clinic. I did my clinic from my bed. And the patients were taken care of because we had figured out telehealth, and I did the telehealth in reverse. They went to clinic, I stayed at home, and the interesting
I had a
part,
day like that too.
really, well, and the interesting part is that, the bus driver or the person in environmental services, they can't just switch what they do. I was, staying alone in a huge condo in downtown Chicago. They're tightly packed with other people. And so that's how we ended up with such difficult time with spread of the disease, and then late presentation, which we've always had in poorer people, the reluctance to go in. And the reluctance isn't just about the Tuskegee study. People talk about that all the time, that, the way there's implicit bias, our people of color feel it. They don't have enough. We don't have enough physicians who look like them to make them feel comfortable. And we still have this, no matter how hard we try, we still have this thing where if you have an African-American male who's not following recommendation, and an African-American male physician walks in and tells them, what the guidelines show and what they should be doing, they're way more likely to do it. So that's painful to hear, but it also tells us that we have to right size our population in terms of, the demographics of our physicians. So we'll work on that. But in the meantime, we struggle with people feeling like they can't trust their doctors, they can't trust the hospital, they can't trust the healthcare system. And so, yes, we do have difficulty with people wanting to come in when they're ill and presenting early enough to really impact the disease in a beneficial way. On the other hand, it's financial. That is, how much is this going to cost me if I go to the emergency room? If I'm uninsured or underinsured, or I haven't all my ducks in a row. I'm worried about, is this going to be my rent and my food? And then the other side of it, when I'm in the hospital, suppose they find something and they keep me, where's my income? I'm going to miss my work. And I had a patient 2 days ago say, I'm sorry, I got to leave. I missed 2 days of job. And if I'm not at work for my 3 o'clock shift, I'm going to lose my job. And then what am I going to do, doc? We had to let him go. So what can you do? And so we struggle with the history. People talk about structural racism or historical factors. Redlining here in Louisville that said that if you're on the west side of 9th Street, there will be no economic development because we're not going to make loans and make investments in that. And so, decades later, so if that's the 1930s, here we are 90 years later, and we're reaping the bad deficits.
Yeah.
Because of that, because we have a group of people with less education, and we're fighting it. Now, obviously, every institution that I've been at has their own focus, and University of Chicago was so much about research and education, and more so about research. So as long as I was publishing, I was happy there. Wayne State, largest single campus medical school, they were all about education. So as long as I was teaching, people were happy there. At Rush, it's all about clinical work and clinical excellence. And as long as I was an expert clinician, everybody would be happy with me there. But I come to Louisville, and I honestly, hearing a bit about it, I think a lot of it had to do with Breonna Taylor, what happened with her and U of L. She was a U of L health employee. There is a sensitivity to all of the issues that I'd like to deal with for the rest of my career. And people say, why did you go to Louisville? It's because they really want someone who's focusing on health equity. They want to go into the community. And so I actually set up a cardiology clinic on the West End, go into the community and try to deal with the risk factors. So my little HEART program, HEART stands for Helping Everyone Assess Risk Today.
I like that.
I call it the Heart of Louisville. or go to a community center or a church, set up a booth, and with our ACC risk calculator, we can actually a finger stick and a blood pressure, we can tell a person what their 10-year ASCVD risk is. And if it's high, we're going to plug you in and we're going to get you an appointment. You may need a coronary calcium score. We're going to try to address your risk. So yeah, I had the heart program in Chicago. I same name, but I actually did change the A when I wrote it up to helping everyone address risk today.
That's nice. So how are people responding to that program? Are you there? Because I'm sure they love seeing you.
Oh, absolutely. And, it's a little tough as chair of medicine to spend a lot of time doing the clinical work, but it's what I love to do. So I'm still doing it. And yeah, we'll screen, it's interesting. We can screen 40 people or 80 people, and about 1 out of every 20 is normal.
Wow.
Yeah.
The way you were saying it, it was going to sound like it was 1 in 20 were abnormal. And that was the irony of the way you said it. And you were like, oh God, that's awful. Right. So, it's interesting. And do you feel, I'm curious because, I think that, and just being most honest about it, I think that I'm pretty savvy. I don't think that I have implicit bias, or at least I thought. But I truly do. I have some implicit biases as well. I trained in Baltimore, and I can a person walks in Baltimore and I've already sort of scoped out in my head, and I'm embarrassed to say it, but I sometimes think, okay, well, what drugs is this guy on? Or, I'm trying to sort of scope out how much they're telling the truth or not. And so if I'm admitting I'm embarrassed to say that, and I've worked hard to correct that issue. But do you feel that you also have implicit bias? And do you feel, as an African-American man, do you also suffer from implicit bias? Or is it something like, I don't think that I have a bias when it comes to women because I'm like extra aggressive with women, but I do have some level of racial implicit bias that I've worked very hard to correct. I mean, do you find that you also have biases? Is it something that we all have that we all just have to actively correct? Because there is that implicit bias survey that I think that all of us should take. And I just thought it was really an interesting survey to take myself and be like, and it really allows for a lot of self-reflection. And I think even the people who think that they are the most open-minded should take it, because I learned a lot from mine. And it made me correct my issue.
I appreciate your saying that. I could say that I had almost the opposite. Yeah, and being when I'm in the clinic, I guess because of my training, South Side of Chicago, Grady Hospital in Atlanta, I have 2 different modes. I mean, when you're at Grady, you've got one population. When you at Emory University Hospital, it's a completely different population. And then when you went to the VA, it's a third population. Yeah. And you have to speak each language. So I'm quoting a Dean Ornishism, treating people where they are. So I'm automatically on the South Side of Chicago, and here in Louisville, I'm bilingual. I can relate to how I grew up and how people grew up on the West End with a similar background. And I can actually put on my South Side of Chicago accent, actually, then if it's going to make them more comfortable. But the implicit bias that I agree with you completely. Everybody needs to be able to go into their mind and figure out. So when I did it, I found something very embarrassing. That is, I'm one of those people who annoyingly will hold up traffic trying to give a $5 bill to the person who's standing on the street. And until I did,
I'm one of those people too.
Well, thank you for admitting that. Until I did the implicit bias training, I didn't actually realize that I had never given a white male. And so what was with that? So this is quoting a Quinn Capers here. Consider the opposite. Okay, when you start thinking about it, wait a minute. If he had white male privilege and he's standing out here on the street in the cold looking for a handout, whatever he went through had to be worse, okay, than what everybody else did. So he's probably certainly the person that I should not be ignoring. And that's a little anecdote, a little embarrassing, of course, but it tells you that we all ought to check our biases at the door and see what it is, how we can make all of our surroundings better, regardless of racial and ethnic differences.
Yes, I love that. I love that you shared that story. It is embarrassing. It was embarrassing for me to sort of notice that I had ideas in my head that I didn't really actually appreciate until I did that survey. So really worth doing. So what is this, what to do? What, like you are making impact as a physician and you are in Louisville, you've got a clinic that you've put on, put in the center of an area where you thought needed support. If you were to say, and we all know that, and maybe this is actually not well known, is that the life expectancy now has, we're starting to trend down, right? So we're not living as long as our parents did. And maybe you can speak to that a little. And then if after that, it's sort of say, what is it as physicians should we be doing better, besides, and this is going to segue a little into nutrition, which is what I was hoping you might talk a little bit about.
It's definitely segueing into nutrition. So let me just start with, if people will look at Jim Januzzi's art, he was the senior author. It was published a couple months ago, talking about projections for 2060 for cardiovascular disease.
Yeah, incredible.
Yes, they are going down, but it's going down in the white population. So that is, the cardiovascular disease is actually going down. So why are we projected to do worse? Because the number of minorities is actually going up faster. Yeah. And so our Hispanic and Black population are projected to get 30-40% more diabetes, obesity, hypertension, and dyslipidemia. And therefore, that's one set of graphs that they have in the paper with those projections. And then below it, of course, is what happens: heart failure, heart attack, stroke, and they're all going to go up. Now, what is our opportunity? This is a window of opportunity. I don't know how many Bible fans you are out there. The book of Daniel, many, many tekel upharsin. Those words that written on the wall. The handwriting is on the wall. If we do not stop this trend of continuing to have bad nutrition, particularly in the poorer people, we are going to end up with an inordinate amount of cardiovascular disease that we just can't financially handle. Unless we take all of our money out of the Defense Department and put it in Health and Human Services and Medicare, Medicare is going to go broke. And it's going to go broke because of us in our community. Therefore, what can we do? I mean, and I always talk about chronic kidney disease, not just because my dad was on dialysis until his sudden death. Well, the fact of the matter is, we African Americans are 12% of the population and 35% of the dialysis patients, and we live longer on dialysis than any other race. Therefore, the moment you qualify for dialysis, Medicare spends about $100,000 per year on you as a beneficiary. That is a huge amount of money that is not sustainable, particularly if the white population continues to go down and the African Americans and Hispanics go up. We have to take it upon ourselves as our patriotic duty to change our diet, change our lifestyle, and change these outcomes, both the disease and the underpinning risk factors that respond to nutrition and the diseases that come from them. So what I've been saying is that, everybody's seen the little graph, and I showed it at the lecture you were referencing, where you've got you're trying to do equality and give everybody a boost so they can see the baseball game over the fence, right? But it doesn't help the really short person, and the person who was tall didn't really need it. So equality is not really what we're looking for. So equity is where you give the tall person a small boost and the medium person a medium boost and the short person a big boost. Great. But then there's reality, which is the third part of that slide, where the rich get richer and the poor get poorer. And if we don't make an intervention on that, we're always going to be behind the eight ball in terms of social determinants of health, because they're inordinately linked, like we said, to finances and education. And they make the wealth is also loops around, because without health, there is no wealth. And because you can't work enough to, educate your next generation if you're sick. Okay, so justice, the fourth part of that slide, is where you just remove the fence. Yeah. Okay. And so since I've had a lot of time to think about that when I talk, because people will say, well, it's not that simple. You can't just make everybody whole food, plant-based diet, exercise every day, and all of the diseases are going to go away, but you will dramatically reduce them. And so the opportunities for healthcare disparities will go away if you remove the diseases. And, if people don't believe it, what happened to smallpox? What happened to polio? What happened to tuberculosis? You had such huge disparities between the white and the Black population, the poor and the rich with those diseases. And, and then you had African Americans back there. I didn't want the polio shot and all of the stuff the kinds of things that we go through. All of it's gone now. We don't have healthcare disparities in polio. Why? Because we got rid of polio. Okay? Right. That's what I'm saying. So we changed the diet. We changed you may still have social determinants of health that are with implicit bias, and we need to do better on all the aspects of things that I've been talking about. But if we just improve the health of the population, the acuity of these differences is going to go down.
I love that. So if you remove the illness, you remove the problem. Exactly. It's brilliant and so impossibly difficult for a lot of people to see it that way, right? And so, you and I spend a lot of time doing a lot of education, but I feel like I am just putting a drop in the bucket, so much of the time. And I feel that the struggle continues to be sort of providing food access and healthy food education. And so, maybe you'll talk a little bit about the study you're doing or that you did in Chicago and what you're trying to replicate, which is amazing. And then the other thing I was thinking about is if we don't get payers to pay, right, then and sort of pay for value-based care, then we, we're always putting out the fire after the fact, right? And so how, we're always there after the fact as physicians. And sort of as part of our initiatives and my mission and yours, it's really to provide that education earlier on. And, doing that though is such a challenge but I find for me, the thing that I've reconciled is I like to work with the residents and the students because I feel like if I can teach them about healthy eating and healthy lifestyle, then I can change the next generation. But impacting change sort of in my local hospital system is a challenge.
I agree with you completely. And working backwards from what you said, I do want to emphasize that we have to impact the next generation. The leading cause of death of cardiologists is still heart disease, the last time I checked. And that's because we do not eat right. And, it's so maybe just a tiny bit frustrating to write guidelines, for nuclear cardiology, and then you go out in the community and realize nobody's doing it. And then hypertension guidelines. Are people really still giving beta blockers? Please read the guidelines, 2017 hypertension guidelines. Now we can move forward to my third guideline, ACC-AHA, which was the primary prevention. And I was pleased to try and author, along with the group, the nutrition recommendations and avoidance of cholesterol, saturated fat, sodium, refined grains, and sugar. Simple things, maybe not the easiest to implement to do, but you can learn how to do it. And when we look at what people are eating in the medical community, it's no wonder that we have the same disease profile that everybody else does. And so we actually did a study. It was presented at American Heart Association last year. Unfortunately, we were interested in what happened with the COVID vaccine because, you take the biopsy of the people around you, and all the vegans had no problem with the vaccine, and all the non-vegans seemed to get a little ill. And I know that was highly variable, but, after this happened 4 or 5 times, we said, well, we should actually study this. So we sent out a survey to find who among our physicians, and these are young physicians because they were the colleagues of my coworkers, young physicians mostly, and then we expanded it to the attending faculty. It was Rush and Loyola. And what we found is 274 respondents, 11 were following the ACC-AHA guidelines. It's either pesco-vegetarian or vegan. That is, everyone else was eating things which we know increases their mortality in their chronic disease states. And so I would double down on what you said. We have to work with the interns and residents. The future of medicine is improving nutrition, and it's got to start on a personal basis first. Okay, but then what is it that we're really trying to do? I would love to take all those physicians, and whenever I can, I show them the data from the south side of Chicago where we measured 15 different risk factors, and everything went completely better when we did a 5-week prospective intervention with a whole food plant-based diet. It was actually, you could say that the data was flawed because we did it over Lent. Lent was a way to get people to do it because, it's a common thing on the south side.
That seems to be a benefit, not a flaw.
Well, except that, how in terms of real life,
Hmm,
I mean, people will give up soda pop or give up cigarettes or something like that for Lent, but then they go back.
right.
And Shrove, Fat Tuesday, that whole idea, and then Easter. Well, at the end of Lent, you're supposed to go back. But
Right.
we were hoping that we would just ignore the
Would
going
not.
back part. And so that was the flaw in the study. We saw dramatic improvement. The biggest were in insulin levels, fell 43%. TMAO levels fell 43%. If anybody not sure what trimethylamine N oxide, please Google those four letters. TMAO, it really is a four-letter word that everybody needs to know about.
New England Journal 2013, Stan Hazen.
Stan Hazen, absolutely. And they have done so much to correlate that with bad outcomes and mechanisms. And bottom line is, if you weren't a vegan before you read the TMAO data, you probably will be afterwards. But everything went down. The weight went down, blood pressure, hemoglobin A1C. The C-reactive protein actually did go down, but it's highly variable because that's the way it is. And so we we made a change, but did we make a difference? And that, so doing the follow-up 6 months later, about 1/3 of the people really appreciated that they came off of some of their medications and they stayed on the plant-based diet. 1/3 had made some changes, but not completely. And then 1/3, we never even heard from them again. They refused to answer. And I know what that means.
Yeah.
Maybe their email went away, but more than likely is that their dietary impact went away. And so we're trying this time in Louisville to do a little bit more. First of all, the criticism, because so many people, if I have, 90 seconds of your life that I can't give you back, I got to talk about the Mediterranean diet because it is accepted in cardiology and fish did swim their way into those guidelines. Why? Because of the Predimed trial. It's got to be one of the most misunderstood trials in the history of New England Journal of Medicine, where that 30% decrease on the Kaplan-Meier plot, that 30% decrease in heart attack, stroke, and death. If you look at table 3, it was all about stroke. That is, myocardial infarction, heart attack was the same in both, whether you were eating red meat, eating Mediterranean with olive oil, or eating Mediterranean with nuts. They were all the same. The cardiac death rate was the same. The overall mortality was the same. So how does the stroke reduction get into the ACC-AHA guidelines? Aha, I'll tell you why, because AHA is a stroke organization. And that's how it happened. They pushed back until we put the fish back in there because of the Mediterranean trial. And that's fine. I can understand that. And if I was a neurologist, I'd be jumping up and down. But as a cardiologist, that is a worthless diet, according to I think there's other data out there that says it's better than red meat, just not that data. Okay. Yeah. Even though people quote it all the time. And so, but we got that criticism that it was a, N of 1, times 50, but an N of 1 trial, that it wasn't randomized. And that so many people are pushing the Mediterranean diet. So yeah, going forward in Louisville, we're actually going to do vegan versus Mediterranean, measure the risk factors before and after 4 weeks, and then crossover so that the vegans become Mediterranean and Mediterranean becomes vegans, and then do the risk factors after 4 more weeks. With that, we should be able to really personalize which risk is better. There's a possibility that someone out there in our population would do better going from the African-American diet to Mediterranean than they did African-American to vegan. I don't think so, but I'm prepared for that. And we're committed to then coaching people, not letting them go like we did last time. After their last set of risk factors, we're going to coach them into whichever diet lowered their risk the most. And we'll keep that coaching up for 4 weeks, and then we follow them up intermittently to make sure that they're capable of actually doing the nutrition themselves, going to the grocery store, being able to prepare them, food demonstrations and the demonstration kitchen, and having a nutrition person expert go with them virtually, of course, to the grocery store and coach them. We're going to do as much intense education this time as we possibly can, and see what happens at the end of 3 years. We're going to focus on people with known coronary disease, measure their plaque burden at first, and then measure it again in 3 years. And hopefully we will make a difference this time, not just a change.
I think that's a wonderful study and admirable. And, I love working and thinking about studies with you in general. So it's been fun to kind of think about that study and think about how we could do something like that in Orlando too. I know we're getting short on time. I thought maybe if you could just end with one thought, which is, what would you leave the young doctors of today? I know that's sort of a cheesy question, but just in a sense of like, what can because when I talk to I gave medical students, the fourth year medical students, a talk on nutrition the other day. And at the end of it, they all smiled. They're like, really great. And other people gave me feedback saying, you didn't highlight enough. You were too biased towards plant-based nutrition, which was a lot of feedback I got. So you're too biased towards plant-based nutrition. And yes, nutrition is a great idea, but that's not practical. What would you say to students like that? How should I answer questions like that? And how do we impact change? Or what would you say to those people, I guess, to sort of say, wait, gosh, come on, let's look at this again. Let's inspire people to make the change.
So it's funny that you had that experience a couple of weeks ago. I was honored to be visiting professor, I think the third time at NYU. And these are really great people. Ischemia Trial, Judy Hockman, these are brilliant people. And I presented all this, reduction of plant-based risk with plant-based diet and all of the mechanisms and the microbiome and the TMAO, presented all of this stuff. And at the end of it, they actually shared something. You and I probably, and maybe people in your audience, remember that Benita Shaw actually did a trial at NYU. It Evade CAD.
Evade, yep.
And it was comparing the AHA diet at the time before we changed the guidelines to vegan, looking at C-reactive protein and seeing that as long as you're eating animals, the carcass of, deceased animals, you are going to have inflammation. And when you go to a whole food plant-based diet, you saw there was a 28% reduction in high sensitivity C-reactive protein. But what we didn't see in the JAHA publication is what they shared with me. They said, exactly what you were told. This is not practical. People are not going to do it. So you can have all this data all you want saying that it's going to make people better, but only the tip of the iceberg of people are going to do it. Why do I do it? Well, because my LDL was really high. And, I'm famously, unfortunately, very famously said, I don't mind dying. I just don't want it to be my fault. And now I kind of have to live up to that. So whenever it gets published, I do. So what they said is that 14% of the people they tried to enroll in the trial after their calf agreed to do it. And this is very disappointing. But what they're saying to you and what they're saying to me is that we have to figure out ways of capturing the population and getting them educated so that they know that the disease that they just got that stent for is something that they ate and something that they can do something about. So we have help. Okay. So I'm going to make 2 points for you. Number one, any young people, we focus on the young people because of Max Planck. Everybody's heard of Planck's constant, but they haven't really thought about Planck's principle. And I hate to actually say it out loud, so I'm going to just have people Google it. And when you see it, you'll be stunned at what it says. But it basically says, how do I say it nicely? I got it. Young people have to take over. That's the nicest paraphrase of what Max Planck said. Okay. The other hope, though, the hope for the future isn't just getting our young people involved. It's the fact that the White House, in the end of September, for the first time in 50 years, actually had a nutrition, health, and hunger conference. And it's wonderful that they were taking a lot of really hard-nosed looks at things that our government has been doing and could do. One of the things that our government does is give subsidies for production of bad things, animal products, high fructose corn syrup, refined flour, sugar, those kinds of things to make them less expensive. And once you do that, then the poor people are more attractive to it because it's inexpensive calories. And then we have to pay collectively for the healthcare of the poor. So why would we do that? Why wouldn't we invest in things that are going to make the population healthier so we can lower our healthcare budget? And so that was one of many, many recommendations that they decided that they were going to try to implement. And I hope they're able to follow through on all the things that they said. So there's hope out there. It's getting a message from the government, A, and B, making sure our young people know exactly where they should be going with nutrition as the most important thing that we could talk about in medicine.
Love it. I love it. Nutrition, talking to the young people. So many important topics today, Kim. You are one of my favorite people. I have to tell you that. And I truly mean that, because I think that you have a heart of gold, but you're just super, it's a pleasure. It truly is an honor to know you. It's a pleasure to have you on here and just chat with you. And I hope we make some impact with this podcast. I don't know. I hope so. But I think the key is you've definitely helped my life, and I do appreciate that. And I think that anything we can do to impact the future and talk to people about nutrition is making impact. So even a small step of talking to your patient in the clinic and letting them hear it, that why nutrition is important, is making impact. And so there's no minutes too small. Just take that time to talk to your patients about it, talk to your students about it. They may sort of say you're over biased or whatever they may say, but it's okay, because they're listening and they're changing. And, I always talk about my son, who, when he was like 9, he said, Mama, I don't like kale. And I said, honey, I love you, but I don't care. And so, and that's really the truth, is that at the end of the day, now he eats plant-based, and he's always eaten plant-based, but now he makes it by choice. And so it's not because it's because I sort of kept saying over and over again about the health benefits. And now this child is completely plant-based, and so are all my children. But it's just, I think that constant reinforcement over and over again. And he still doesn't love kale, but he eats all plant-based. A pleasure, Kim. Thank you so much.
Can I just say 2 more things?
Yeah.
Okay. The famous Kim Williams kale chips. Okay. You got to get him to do it. Okay. I'll give you the recipe offline.
Okay.
It's blackened kale. He will absolutely adore kale.
Really? Okay.
Number 1, blackened kale. The other one is, Dr. Agarwal, you crossed the line. You said so many wonderful, nice things about me. I was either going to tear up or start talking about you. So I'm going to do the latter. Okay. No. So I just need you to know what an impact that you've had in all of our work groups, publications. Okay. But I fought at Rush University while I was chief of cardiology for 9 years to get them to change the menu. So I'm not telling the person one thing when they come out of the CCU, and then the tray says something else. And you actually did this. And it turns out that with a cadre, mostly a medical student and myself, of people using your data, you and Rob Asso, using the fact that you changed it at University of Florida, he did it at Montefiore, we showed them how you could do it because you published that, and Rush changed.
Oh, I love that. I love hearing that. I didn't realize that Rush had made that change. That warms my heart. That's wonderful.
Thank you so much.
It's been a pleasure. Thank you so much.